Just explain, I was the Minister of State for Care Services a long time ago, and Minister for Social Enterprise. But since coming out of government in 2010, I was the Minister under the Brown government at the time. I've been working as an advisor to a whole range of organisations about the health and social care landscape, among many other things, and how to navigate that landscape well. And other roles that I hold at the moment, I'm visiting professor at Imperial College, where I lecture on the politics of health policy making to master's students, people in the health and care system who want to understand how decisions are made. And I'm also a charity trustee of a large health and care charity in the southwest, Brunel Care, and I'm a commissioner and lead author of the Health Devolution Commission, which is a group that sort of think tank group that look at how we can promote better integration between health, social care, public health, and indeed the public health realm as the public realm as a whole. So that's about me, and I'll ask Sophie if we could put up the agenda, start the slides. But just to say to you, we're going to get into quite a lot of, I call it an alphabet soup of acronyms, which some of you may be very familiar with and some may be brand new. I'll try not to use jargon, but it's almost impossible when discussing something like the health and social care landscape to avoid those. So just stop me if I'm going on about something that you've never heard of or don't understand the acronym for, or I haven't said what the acronym means. We're going to cover these. I think these were sent out in advance of today's session, and there's a sort of a logical sequence behind looking at the challenges, the concepts underlying the new system, the structures, the challenges and the risks, and then maybe the opportunities for you as social enterprises. And my intention is to go through this at a bit of a gallop, because there's a lot to get through in the hour, because I know that some areas will be very familiar to you and we just want to get moved on, but for others it may not be. So please do interrupt. Just say, excuse me, I want to, could we say a bit more about that, please? Or literally don't understand what you've just said, please, can we go back over that? Or if you want to go into a deep dive on something, just say so as we go through, and I'll try to pace it as we go along. So that's the agenda for today. So without further ado, let's get into the first bit, which is the key challenges facing the health and social care system. Next slide, please, Sophie. Now, this is my little diagram. Now, I'm not great at diagrams, I must admit, but this is an attempt to try and capture in a sort of a schematic way what might be going on in a geographical place. So starting on the left-hand side of this slide, I just wanted to say we have a situation in most parts of the country where we have an aging population, so people with more health and care needs. We've got a growing population, so more demand on the services. We've obviously got new treatments always coming along that costs money. At the moment, we've got a backlog because of COVID of treatments and diagnostics that aren't happening. And of course, we have the cost of living crisis, growing poverty, a real poverty, and the links between that and health and ill health are well known, all of which are putting pressures on the system. So the next bit is the blue bubble, and that's the sort of community, hence it's got bubbly edges, which comprises a whole range of people, GP practices, community health providers, some of you maybe those that yourselves now, mental health trusts, the social care system, a range of providers and the council, and of course the voluntary community and social enterprise sector, sort of all of the community. I've not covered everything there. There's the people and the different dynamics. Now, what's going on then? What are these challenges that are going on? Normally, we would hope that there would be few unplanned admissions because we know how people are, and we try to prevent them getting ill enough to have to go to hospital. So we want to get elective admissions into the black box there, which is the hospital. Now, I often think of this as like a gravitational hole, a black hole in the system, where a lot of people, and too many unplanned admissions at the moment, go into hospital, and that's where all the money goes, that's where all the patients go, and end up are not able to come out again. Once you cross the threshold, as it were, with a black hole, it's difficult to get out again. In fact, it's impossible in a black hole. But anyway, here, the problems for hospitals is that they've got too many people staying too long. The length of stay is too long. They may be clinically actually made better, but the detox, first bit of jargon, delayed transfers of care, the delay in the transfer of their care out of the hospital through a discharge system means that those beds fill up, and which means that you can't get any more in. And that's, for many of you will know, is a large part of the agenda at the moment, particularly with trying to tackle the backlog from COVID, is how do we get people in and out of hospital quicker? And indeed, for many older people, going in hospital is the last place you want to be anyway for your clinical care, unless you really, really need to, because hospitals are not healthy places. And very often people come out of hospital not as well as it were before they went in. So this then goes on to, yes, we need to have a good discharge system for people back into the community, to have their ongoing care and looked after at home, maybe with the support of a district nurse. But sometimes people can end up being readmitted back in the hospital because something went wrong, they fell over again. That's a typical older person with long-term conditions, has a fall, goes into hospital, has it treated, comes out, has a fall again, they get readmitted. So you've got a real problem of this kind of movement of people into the hospital system, which is where the money ends up going as well. So, but let's assume you get care at home. The question then is, for some people, if they can't be cared for at home, they need to be cared for in a residential setting, mainly older people, but children too. But that's very expensive and is often not the best place that people often want to be looked after in their own home. So that's the kind of what's going on, and people are intervening in this system to try to reduce these problems. So on the left-hand side of the diagram, on the red, can we do something about some of the determinants of ill health? And I'll come on to that a bit more in a minute. Some of the wider determinants of ill health that are going on, things like poor housing, air pollution, and so on, that make people ill in the first place. But generally speaking, let's go back to the hospital. Can we have better discharge systems, home from hospital services, for example, that reduces, LOS reduces length of stay and reduces readmissions, because people have proper home from hospital services. And that's where you have the collision, as it were, between the NHS and between social care, where people have not got the ability to be cared for at home because the social care system hasn't got the resources to provide the social care workers, the care workers, to keep somebody well in their own home. And I'm going to come on to how the new system, the integrated care system, is trying to solve that problem. The middle green box that you can see is, can we do something about stopping people going into hospital in the first place in these unplanned admissions? So there are schemes in different parts of the country where you target prevention services on people at most risk of an unplanned admission. So there are systems that can be used through the data sets that the NHS and social care system holds of people who are highly risky of going into hospital for an unplanned admission. It's called risk stratification. Imagine a triangle. People at the top of the triangle are highly at risk of going into hospital through an unplanned admission because they're so unwell, they're more likely to fall over, their condition will deteriorate and so on. And at the bottom of the triangle, most people aren't at risk. And so can we literally identify the individuals, the Mrs. Jones or the Mrs. Singh or whoever it is who's at most risk of an unplanned admission, and get to her before she has the incident that would lead her into hospital? So there's those sorts of measures underway. Some of you may be involved in actually delivering some of these systems. And then on the left-hand side is the development that's happening now through integrated care systems of trying to, that blue bubble of all those people working together in a new partnership at a place-based level. That's the level of a local authority, NHS, like social care, public health, etc., all working together, mental health trusts, GPs, and so on. And what's called the neighbourhood or primary care level, a much smaller geographical patch within that. So creating small geographies within the geography of a place. I'll say more about that later. So that's a sort of a schematic of, I find it helpful to think in diagrams of what's going on and what people are trying to do, what this system's all about. Let's move on to the next slide and take us on to the next look at the thinking. So the key concepts, so as our busiest slide this, I won't just read them out. So, but they created these new integrated care systems. There are 42 of them around the geography of England, with geographically based. And an integrated system, interestingly now, is much more than a health system, because the four aims of an integrated care system, which are there, and I've reproduced them. Yes, there's about improving outcomes in population health as well as health care. So that is saying we're not just going to provide a better GP system of getting a see a GP or a better hospital service. We're going to try and improve outcomes, population health improvements, outcomes, as well is the purpose of an ICS. To tackle inequalities, some of the government now talk about disparities rather than inequalities. That's a kind of political choice of language, in outcomes, experience and access to services. To enhance productivity, getting more bang for your bucks and value for money. And interestingly, an ICS is there to try and help the NHS to support broader social and economic development, because of what we now know about the drivers of ill health, which might be poor economy, poverty, poor social circumstances and behaviours. And that means that the system is trying to address these wider social determinants of ill health. And you'll have come across the work of Michael Marmot, I'm sure, who's done some excellent work exposing, as it were, that in truth, most solutions to the health of the nation lie outside of the NHS, that the drivers of ill health do lie in poor air quality, poor housing, and poverty, rather than in whether or not the hospitals efficiently run. And that leads the local providers to be thinking about this idea that we should be thinking about health in all policies. So when a local council, when a local provider of other services like housing, like transport, like education, what is the health impact, what are the health consequences of their policies? Does it help improve the health of that population, or does it actually not improve it? And you think about the current row that's going on in London, where the mayor is trying to extend the ULEZ, the ultra low emission zone, is because he's saying, well, okay, the policy is to reduce congestion and it has a massive health impact, positive impact, if we do it. And obviously there's people that don't like that because it's paying more for transport. The other side of that coin is that the NHS can do better and achieve its broader social and economic impact if it sees its own influence on economic well-being. In other words, we want to see how hospitals and others, big anchor institutions, in the way that they employ staff, locate their services locally, their supply chains for their products, all of that could be done in a way that has no impact on the local people of any benefit, or it could be done that it has a huge impact on the local communities. And there's a lot of thinking going along, particularly by the Shelford group of hospitals, which are the big teaching hospitals around the country, to say each hospital should really be looking at all of its decisions about how it buys, who it employs, and so on, so that it's having this wider positive impact on the community as an anchoring institution. Everyone's now talking about the health service having a whole person centered approach, not just thinking about that disease or that organ that's going wrong or that limb that needs treatment, thinking about the whole person. And that is frankly a huge culture shift for many people in the health service who have rightly been trained to the nth degree about that particular organ, disease or limb. But actually, if we're going to solve the wider demand on the health service system, they have to think about the whole person, because just fixing the hip is no good if the person then goes back home and can't walk up the stairs without falling down. And also the new thinking is about a place-based approach, like that diagram I showed you before, how everything interacts with each other and should be doing so in ways that are mutually supportive, not contradictory. So at the primary care level in locality networks, thinking how can we maximize and value everything that's available in the local community. And a bigger emphasis, and this is a huge challenge at the moment with all the demands on the system, that we shouldn't keep on talking and spending money about treating people. We need to prevent people getting ill, or really intervening very early in illness to prevent it getting worse and providing more costs. So you may know that a lot of more people are being diagnosed as pre-diabetic at the moment, and that's an example of how GPs are being encouraged to find those people, and provide interventions then to prevent them getting the diabetes that then leads to the huge cost and the poorer quality of life they lead. Sorry, I'm talking a lot to this slide. My apologies. Some of the big issues that underpin the integrated care system, therefore, are to do with equality and parity between the NHS and local government, which is very different because in the past NHS has stood alone and separately, and including in local government there, social care, children's care, public health. Something that's been a long ambition is equality and parity between physical and mental health within the NHS. There was an NAO report that came out in October saying some progress, a long way to go, and some very much more clarity needed. So the NAO is the National Audit Office that inspect the system. They're saying more work needs to be done. Worth looking at that report. Another key concept is a voice for people with lived experience of care. Can we absolutely show? And this is not something that it's very common, I think, in the world of social care, less common in the world of health, is giving people lived experience a voice, an opportunity to say what their experiences are, how they have felt, what actually happened to them, and to have that measured and used as a tool for performance improvement of the system. Certainly, if you're going to do any of this wider agenda, you have to have a partnership with local community organisations, voluntary organisations, social enterprises in your patch. Not just as a means to achieving the NHS goals, but valuing that sector in its own right because of what it does, maybe in reducing isolation, giving support, being innovative, and so on. And I'll come back to more about, for you as an audience, where you might be able to play on this. Much more about community engagement and activated communities. I think as a result of COVID, when lots of volunteers came forward, the NHS went, oh, right, there's people out there that can really help us. We don't have to do this alone. We can actually get engaged with communities, and that can be very important. You can reach out to communities that the NHS has failed to reach out to in the past. You can really go forward. And if you are going to integrate the NHS with local government, then you're going to have to decentralize, because the way the funding works is local government money is bounded by the local government boundaries. So the NHS is going to have to think about how it structures its finances at a local level in a decentralized way, so that it can align, even join with social care budgets. So you can't have integration without decentralization. And therefore, it's not always in the NHS about looking up for accountability to the government, but looking out sideways to democratic institutions like local councils for mutual accountability, and indeed to local partners in the voluntary sector and so on. And that enables you, if you really go down that path in a big way, to do this idea of joint planning for a health and social care workforce. And at the moment, the narrative is continually about the health workforce, and we haven't got enough nurses or doctors or whatever. Absolutely true. But recruitment and retention is even more important in the social care workforce, where we've got something like 160,000 vacancies. And therefore, we can't deliver the social care. If we can't deliver the social care, as that diagram showed, then you can't get people out of hospital.
Phil, Kirsty's just put a comment in to say that she feels that it goes beyond the comment about lived experience. She says that as a lived experience leader, services can also be delivered by people with the lived experience.
It's a very, very good point. On the Health Devolution Commission that I'm a member of, we have 2 people with lived experience on as commissioners, and they make that point, and we have listened carefully to that point. It's really important that people can be co-producers, co-designers of services that they need. Again, it's a sort of culture that I think in the world of social care, disability rights and so on is quite common and normal to local councils. But it's not the norm for the NHS. And if we're trying to integrate systems, and because of what I was saying earlier, then there's again another culture shift. I think the NHS might be good at panels, forums, consultations now. Perhaps I hope they are with people with experience. But moving to that next stage that you say, Kirsty, that can actually be delivered, co-designed and delivered, is another step that I think many people in the NHS have got some way to go still And actually, examples of best practice on that are really important. We work with Mencap, Bernardo's and others who are trying to show, yeah, it can be done and done well. Thanks very much. Thank you, Lucy, for that kind of, drawing my attention to that. It's really good. I'm going to keep going unless people stop me. So I'll move on to the next one, which, thank you, Sophie. So this is taken from the white paper the government produced just before the bill went through last year, which is a structural diagram. Now, for people and politicians like me, we love structural diagrams, but I'll try not to bore you too much with this. But navigating your way around the landscape actually is about trying to understand what's going on. So let's start at the top and work down. You've got the Department of Health and Social Care, and we've got the Department for Levelling Up Housing and Communities as the two core departments, health and social care, or health and local government. Just to obviously say, above that diagram, we've got number 10 and we've got the Treasury. And I mention those because as a minister in the past, when I was trying to get everything, as it were, in the rest of the diagram to work well, unless I had Treasury support on the money side and political support from number 10 on the political side, things were very hard to get done in any kind of big way. You're allowed to do little things on your own, but you really, so what's missing from this diagram is the fact that internally within government, within Parliament, within cabinet committees, there's a whole bun fight that goes on between the departments, the Treasury and number 10, and all the special advisors, the people behind the scenes that you never see fighting it out. Anyway, let's move to the diagram. Obviously, we have arm's length NHS England and improvement. Well, we just call it NHS England now. And what they've created are the integrated care systems. And crucially, as you can see, that blue box is where everyone comes together, but it is in two halves. The integrated care board, where most of the money sits, and the integrated care partnership, which is a much bigger partnership of a much wider group of organizations and can be designed. There's much more flexibility in the system. So written into law is who can be a member of the integrated care board and how it works and so on. Much more fluid and open to local flexibility, local decision making is how you run your integrated care partnership. So if I was looking at it with a political lens, I'd say the power, the money is with the Integrated Care Board, but the Integrated Care Partnership has got a much bigger strategic position. And as this system is maturing, people are beginning to see, or the view would be, that the Integrated Care Partnership, the big strategic body, sets the strategy for the whole geographical patch, the priorities and so on, and which the Integrated Care Board should then make real by delivering it by its spending decisions and spending allocations. In truth, the worry is that most of the power lies with the board, and the care partnership doesn't have that kind of presence in the system that it needs to be an equal part of it. So that's the debate that goes on from one ICS to another. And you can see that the geographical size of it, the local government box on the right, says that within an integrated care system, you might have 3 to 5 top tier local authorities, social care providing local authorities. In Northamptonshire, for example, there are 2 unitary authorities that make up the integrated care system. It's one of the smallest ICSs in the country. I think in the northeast, in Cumbria, it's huge. It's a vast geographical patch covered by the integrated care system, so they do vary in size. Okay, that's the system level. Then you come down to the place level, the red box in the middle. Now, this is where at a local authority, each local authority, top tier local authority, in 2-tier systems, it would be the county council, or it's a metropolitan borough or a London borough. They have a single integrated health and social care board at the level of place with a single point of accountability, where ideally the money is pooled, the health money and the social care money is pooled or aligned, not the hospital budgets. And that's the big kind of question mark, is the integrated care system does have oversight of the the hospital part of the system, but the integrated place boards don't. They would need to interact with those hospitals, but they'd have no power over them. And if you remember my diagram, that's a big question. We think that the reason why you have ICSs is to have a big enough footprint over, say, 5 local authorities to really then be able to marshal and bring into the system in a very equal way hospitals, rather than sitting outside the whole system, because there's no use us organizing very nicely at a level of place if the hospital is still doing its own thing and not really engaging with the wider system. And then below the level of place, we have being a delivery. So the left-hand box talks about primary care network. So that's GP practices. I'll say more about those in a minute, and linking together with all local services in a patch. You'll have mental health services, adult social care providers, and hospitals and other healthcare services who are, as it were, delivering at the front line. And the arrows just show, from the white paper's point of view, the flow of money, commissioning decisions, place-based integration, and so on. So I use this diagram not because it's the perfect diagram, but because it's the government's diagram, and that's how they see the world. So knowing how they see the world is a really important part of us engaging with it if we're going to be successful. One other item that's missing from here is this idea of provider collaboratives, and this may be of real interest to you, which is in a integrated care system, there may be a decision made to pull together everyone who's, say, concerned with mental health, all the providers of mental health services in that area, call it a collaborative, and that collaborative will be responsible for designing the mental health strategy for that area, thinking about the priorities, and then giving advice to the integrated care boards on and partnerships on how mental health is improved in their area. It could be that they could be delegated commissioning responsibilities, and that one large provider could be given the job of commissioning services from other smaller providers within the collaborative. That's all work in progress and varies hugely from place to place. In some cases, the collaboratives are forums, no more than that. In other places, they actually have a real role to play. Okay, in the absence of questions or interventions, I shall carry on. Sophie. Okay, so I mentioned these at the lower level, the primary care neighbourhood network. So just to be very clear about this, the levels in that structure we've just seen relate to population sizes, the left-hand part of this slide. So integrated care systems, a population 1 to 5 million, 42 of those covering England. Place-based working, on average, about 1 million people in a unitary authority. But within a place, there would be a neighbourhood primary care working of covering a patch of 30 to 50,000 population. And there was Caroline Fuller, who's a leading GP, did a stocktake of primary care. I can't go into the details of everything she said, but it was really important, which was that she said, okay, primary care networks, which are largely GPs and clinical directors, lead people of GPs in a patch, 5 or 6 GP practices in a primary care network working together, and trying to coordinate in a geographical way, need to evolve into what she described as neighbourhood teams of teams, because then you can involve the social care system, the voluntary sector, social enterprise sector, the voice of people living in that area, residents, patients, people who lived experience of care. And they would have a real job of trying to find ways of, in that patch, streamlining people's access to care and advice. These are people maybe who only use the health and social care system occasionally. How can they do that quickly, easily, and well, get the care and support they need from their GP? Then for people with the second strand is this personalised care from a multidisciplinary team. Not everyone needs a multidisciplinary team, but people with complex needs, people with multiple conditions might well need a targeted multidisciplinary team approach. So that's going to happen at this neighbourhood level. And I'm with the ambition that in your patch, so this is quite a small patch, how can we help people to stay well for longer, engaging with the community, running community events, doing community public health exercises and the like, and getting people to really sign up to the idea of making their community a healthy community. Although that's clear on the slide, I have to say it's very opaque and muddy at the front line, because I've been working with primary care networks around the country trying to develop this model. Part of the problem, I hope this isn't too much detail, is that the whole idea of ICSs, place-based partnerships down to primary care level, has come as a kind of top-down way of thinking. We want to devolve down through those structures. But the primary care networks was set up as a totally different strand of work by central government with the GPs to set up primary care networks, partly to try to give mutual support between GPs, get rid of single-handed practices and so on. And the two are sort of, once the design of the whole system for primary care is coming from the bottom up, and price-based partnerships, and there's a sort of how these two dock together, and it's actually proving quite hard, because in local authority thinking and place-based thinking, your primary care patch would be literally a geographical patch like the local authority patch. But in NHS land, in GP land, it isn't like that. You might have 5 GP practices covering a population of, say, 50,000 people, scattered all around the local authority area. And then another group of 5 GP practices with 50,000 scattered around exactly the same local authority area. So those primary care networks are not physically, geographically bounded. They're just groups of GPs who have decided to work together because they like one another, they know one another, and are not related to a particular neighborhood, geographical neighborhood. So over time, the vision might be that over time, those primary care networks would become more geographically oriented, but that requires more change to go on among GP practices who are not actually in the mood for much change at the moment because of the pressures they're under. So that's too much detail, but I just think it's interesting to, and some of you may be well involved in some of those discussions at a local level. All right, let's move on. So I've just tried to pull out a few things that are going on at the moment facing some of the system leaders that you're maybe working with. So we know on the current challenges, there's loads of unmet need, increased demand, and the more we do in terms of analysing health of population, the more unmet need we discover, which is not helpful because there's more demand. Patricia Hewitt, who chairs an ICS in Norfolk, has been asked by the government to do a review, the Hewitt review of accountability. I very briefly mentioned the idea of not looking up, but looking out for accountability. Well, that's a tough ask to get that vertical and horizontal thing working well, because who sacks you basically is where the accountability lies. At the moment in the NHS, you get sacked by NHS England, the regions, and your bosses in the NHS. So it's a bit crude, but if we are genuinely talking about this place-based approach and these integrated care systems, there needs to be mutual sideways accountability. And there's a discussion now going on about exactly that, where the power lies and to what extent the national targets, which drive the NHS endlessly down the route it's going to go, should be shrunk down to a minimum number. There should be maybe some national targets for those other aspects like improving the public's health and improving the local economy that the NHS might have to take on board, but lots more flexibility for local criteria, local priorities for which there is local accountability. Anyway, that's a big debate, and the Hewitt review comes out in theory this month, maybe the beginning of March, with recommendations, and whether the government will go down those roads, we don't know. Again, those success measures for the wider ICS aims, that's a big challenge. So you're a system leader or an integrated care system, you may even be a hospital chief executive, and you're thinking, okay, I've got to do something as a hospital about the wider population health, but I just run a hospital, well, but no longer are you just running a hospital. You're now part of a wider system with wider aims. And the extent to which budgets are going to be aligned, let alone pooled, let alone aligned, is a very good question, because when push comes to shove, there's a bit of a fear in the social care side that once again the NHS will nick all the money. I say once again, I'm coming in as a former Minister of State for Care Services, and the NHS are worried that if they share their budgets and decision making with local people, people will make decisions that they are outside what they think is their clinical ability to do so. So there's a bit of an argument going on there. Most of the people I've been working with in ICSs are very, very keen to create these partnerships with the voluntary community social enterprise sector, with engaging with communities and with patient voice and those with lived experience. I just think they're not quite sure how to do it. It's because it's always got to be more than just a seat at the table, although a seat at the table would be a step forward. It needs to be a cultural shift that happens not just at the level of a board meeting, but at the frontline conversation between a patient and a GP. It needs to happen, and as Kirsty was saying earlier, thinking very differently about those patients being actually providers of the care, not just recipients. But of course, the NHS culture is very much one of expert and recipient of expertise, not realizing that the person who is the expert in their own life is them, not the doctor. And the idea that a patient or a person is the expert in their own lives is something that the NHS is still trying to get its head around. There is this primary care reform all that I was talking about before. Interestingly, children's health and care is now under the auspices and within the scope of integrated care systems, which it wasn't before. That was a later amendment to the bill when it went through the Lords. So there's a lot of work going on. If any of you are involved in children's health and care, on developing, children and young people's health and care strategy, what's the framework for that? We've done a lot of work of that in the Commission. So there's work underway, and that's worth engaging on, because it's, relatively speaking, you've got. Question is, schools, if you're going to improve children's health, then you've got to engage schools, because they have a massive impact on children. And of course, it has to be families as well. And so there's a whole, it's not bringing new partners into the system. The education system, for one, to improve children's health and care becomes a much bigger objective. And then something we do a lot of work on the Commission is, I call them the overlooked. It's I just think that people with learning disabilities, autism, we know that their health is outcomes are so much worse than other people's, because the system doesn't know how to respond or work with people with particular conditions or on the spectrum. And it's easy just to ignore it rather than deal with it. So it has to be continually raised up the agenda, otherwise it doesn't happen. And indeed, young people's mental health. I think there has been movement, as the NAO report that I mentioned, on adults, but on children's mental health, particularly waiting times for things like eating disorders, have gone rapidly backwards, and COVID has had a huge impact on young people's mental health. And people have talked about another pandemic, if you like, of mental illness among children and young people as a result of COVID. So there's work there that needs doing. And just lastly, published last month, the government have published what they are calling the Major Conditions Strategy. Definitely worth looking at. They have decided that rather than having a separate strategy for mental health, for dementia, for various conditions, they've put them all these together, the major, what they see as the drivers of ill health in the system, into one new strategy that they're going to be developing. Some people have been cynical and said, oh, that's just because they don't want to publish these single issue strategies, and this is a way of getting past their commitments to publishing them. Others saying that's great, we're now actually got a coordinated way of thinking about how the major conditions, people having them and how they work. So I won't say more about that because it is very new, work in progress, but I think it will be have a big impact on the work of local integrated care systems. Just moving on to the other side, the risks that are around because of the pressures that are on. I hope I've sounded optimistic about this new system and its potential. What we're worried about is people, under the pressures they're under, will retreat back into silo thinking and silo behaviour, particularly acutes and people demanding money and so on. And we'll end up with going back to a really narrow focus in the NHS on treatment and clinical care. And inevitably less priority will be given, because they're focusing on other things, to reducing health inequalities, which is a core purpose of an integrated care system. And certainly, unless we fund the social care system, then all of this is words on paper, because with that many vacancies, the poverty pay that many social care workers experience means that people aren't getting the care they need, and therefore the NHS, because it is a whole system, as I showed earlier, simply can't succeed either. A failing social care system inevitably means a failing health system. And there's a risk in doing all this that my diagram reduces social care to simply solving patient discharge from hospital. In other words, forget that this is a whole system with a purpose and a value and a way of working that is absolutely crucial. And we just end up having debates about, have we got enough social care to get people out of hospital? That's necessary, but it is certainly not sufficient a way to think about social care. The integrated care partnerships that I talk about as a risk, they do become just talking shops rather than having real traction over the system and over the ICB, and the integrated care boards although they have local authorities as equal members and other partners on there, they can become dominated by the NHS. So I flagged those up because the more we say them, then hopefully the less likely they are to happen. Let's go to the next slide. So I was thinking, you're all social enterprises, or at least to some extent connected to this system. And I'm aware there's somebody from a university there as well. And there are opportunities, I think. So one of them is, I think, however big or small you are, engaging with this new system is critical for you to do, either to influence the direction, the policies they make, or to become much more used by, commissioned and seen as being a solution provider. Now, it might be depending on size and what you're about, whether it's at the IC board and IC partnership membership partnership level, whether it's in the place-based boards at the county council or borough council, metropolitan borough council level, whether it's in these neighbourhood networks or whether it's in these system collaboratives. I think it's important that you engage with those people and try to, those system leaders at those levels, seeing that your stuff and their stuff, your stuff looks like their stuff. In other words, you're solving their problems. So you can help reduce pressure and demand on the system by the way you deliver the services you deliver. You can help reduce health inequalities, a key task that they've been set. You can help to address these wider social determinants because you're not just doing a frontline service because you engage with volunteers and all the rest of it in communities. And because you are person-centered and community-oriented, the thing that the NHS is not so good at, you are good at. So you can add value, cost-effective, you're innovative, you're connected to your localities in ways that perhaps others aren't. We know that social enterprises are much more flexible and responsive to changing needs, and that's a valued attribute. And that you can reach out to priority target groups where they're underserved by the current system and need to be served. And indeed, good at supporting the voice of those with lived experience of care. And basically, you're a good partner to work with. So I think if that is all true, what can you do next? And this is the final slide.
There's another question that goes back to the previous slide, I think.
Oh, I'm sorry.
Kirsty's asking about the NICE guidelines and how they can fit.
Yeah, very good point. Thanks, Kirsty. NICE guidelines will continue to exist because they are clinical guidelines on best practice rooted in an evidence base that people then can use and justify their decisions and their spends. So NICE guidelines will continue to be produced by NICE independently as guidelines for best practice in any part of the system as well. Interestingly, so I think that will carry on, and that's a good thing that it carries on. What's more interesting in a way, Kirsty, is the issue about the regulators, the CQC and Ofsted. So if you don't mind, I'm going to piggyback your question to just say a bit about that. And sorry, let me just address your question. There are no NICE guidelines on treatment of complex systems, and I wonder whether the ICSs being a more powerful bodies now might well say we would like to see guidelines like this. And it might be that if people got together and thought about that specific problem you've given, for example, about a diagnosis that's not recognized in NICE guidelines, that these new bodies might become platforms for that kind of clinical discussion. I don't know is the answer, but it might be provide an opportunity. But to move on to the point about regulation, interestingly, obviously CQC basically regulates providers to make sure they're up to scratch and so on, give them their ratings and so forth. The question is, how will these new structures, the ICSs and the place-based partnerships, be regulated or inspected, and under what basis? There is I believe they should be regulated as to whether or not they're achieving those goals that they've been set, and to what extent they do work in partnership, to what extent there is integration and pool budgets and so on. The CQC could then be a kind of a very effective mechanism for promoting this new approach. The risk is that they will simply do all the inspections of all the providers in an ICS patch, add it all up, divide it by the number of providers and give a score, as it were, and say, well, this ICS is not succeeding very well, or this ICS is doing very well, based on an assessment of providers' performance, not on the critical thing, which is how all these providers work together, the partnership working, the, you know, no more people bouncing around the system, being handed off from one provider to another, or bad behavior. So that's what I think the CQC should be inspecting if they're going to really help this system mature. Ofsted is another very interesting, because they inspect schools and education establishments. Well, if the ICS wants to see improvements in children's health, it wants to know that there's a school, that every school is a healthy school, then is Ofsted inspecting to make sure every school is a healthy school as defined by the area. So I think there's a lot of work to be done on linking up. And then, of course, how does Ofsted work with the CQC? 2 inspectors, because what you don't want is one set of guidance, inspection regimes, judgments and assessments being made at the same time as another outfit doing the same thing, but from a different perspective. And then you end up with double working, lots of pressure on people, and in effect, making the system unmanageable. So I don't think I've really answered you well enough on that, Kirsty, but I do agree with you. This system sits outside this system and carries on being what it is, separate from it, but could be influenced by it. Now we're shifting power to different parts. Okay, let's just go back to the last bit. So I just had some thoughts, and these are just ideas. So wherever you are, whoever you are, I think it's, and you've probably do this work already as providers, create a local stakeholder map. I mean, all the pieces are moved around now. New people, same people in new jobs, old people, new people in new jobs. Who's around? Who's making decisions? Where does power really lie? And what are their priorities? I just think that's worth doing, whoever you are, when you're reliant on, you know, commissioning and services, and you want to have an influence. I do think, again, you'll be doing this as a standard part of your work, I'm sure, but so what are your key messages about yourselves and what you want to achieve, and the contribution you could make? And as I was saying earlier, your key messages have got to play directly into the priorities of those key players. I can remember as a minister, people turning up, lobbying me very hard for for their priorities, but they weren't on my priority list at all. So it was an interesting conversation, but if it wasn't going to help me as a minister achieve my priorities, well, that was an interesting conversation, but it hasn't had any impact. So really understanding the person you're talking to, trying to influence in that system, what are their concerns, what are their priorities, how do we shape our messages to show that we can help them achieve their priorities? Critical part of influencing. I think there may be, in everything I've said, and we've scattered over it very quickly, there's going to be some risks from the changes, I guess, for some of you. So what are those risks, and how can you, what can you do, what can people do to mitigate them, and those risks, and having a conversation? So, for example, one of the risks perhaps in a provider collaborative is that the social enterprise isn't included, or in the commissioning of the ICB, they decide we're not going to go out, you know, because competition is no longer a part of the system, it's now based on collaboration. If you're not a part of the collaborative, you're not seen on their radar, does that mean your service and the commission of your service is at risk? So think about those risks and what you might be doing to try to influence them. There will be, because I know, because I'm doing some of them, there will be loads of local development events going on at the borough level, at the place-based level, for collaboratives, for establishing place-based partnerships, for localities, for primary care networks. I mean, what I would say would be, I know that this can feel like you go to 10 meetings, you get nothing out of it, but there's a bit about visibility, being there, being involved in the discussion, making good contributions, being seen, and then people following it up. That, oh, I'm really interested in what you said at that meeting. I mean, we'd like to involve you a bit more in what we're doing. That stuff is, you know, those relationships you build by turning up and being there and performing well and demonstrating your stuff. That all has impact. It has value, and it's all part of the process of how organizations and networks work. And just lastly, this is something Lucy said, it may be, I mean, there's going to be an election in 2024, 2023 this year is a kind of clear the decks year as parties start to build their manifestos. Now, I don't want to get into the whole area of politics, but I thought I might just say a few words from what might be going on in terms of the Labour Party, because I used to be a Labour minister and still connected to bits of what's going on. I think, but overall, you need to make sure, and I guess this is for Social Enterprise Mark and other national bodies to be thinking about for the sector, but is the social enterprise sector going to be at the centre? Is it going to be part of what's going on? Is it reflected in the manifesto? Is it going to be mentioned, talked about in the manifesto, or not? And I think it should be, of course, but you might have to work hard to make that happen. Labour is still thinking about what it means by a national care service. That's part of its work that's going on at the moment. This was something that Andy Burnham and I coined the phrase in 2010 with the white paper. And just to be very clear, it is not a nationalised care service. I know in subsequent years, parts of the Labour Party in recent years thought that's what it meant. It isn't what it means, but it does mean national standards, national qualifications, maybe national pay scales. There are ways of doing national which isn't nationalisation. So there will be lots of providers of all kinds in a care service, but with a much more national standards to work to, so that people get a similar kind of service wherever they are. Similar in terms of the standards, the way it's delivered will be different in Birmingham than it is in Norfolk, because one's rural and one's urban and so on. So, but that's the National Care Service. There is, you've probably seen in the news, reform of primary care, where to try to really, we've had a system where GPs have been the gatekeepers for people to services. Is that system now needing to reflect the modern day? People maybe to access specialists a bit more easily, take the pressure off GPs, maybe enable and support GPs to be partners with the rest of the health service, whether it's district nurses, physiotherapists, which is already happening in partnerships, but also then with social care, public health, and the wider realm, the public realm. Workforce will be another area where people will be thinking hard about what needs to be done to deal with the challenges in the health and social care workforce, and Labour's thinking about that, and maybe manifesto pledges around the pay and conditions of care workers, in particular social care workers, may be important. I suspect there won't be, don't know, but I suspect there won't be any more reform of a structural kind. That those diagrams I've been showing you, I think, will probably stay that way, not least because the NHS does not need, well, it needs like a hole in their head, another major structural reform. We need to make work what's there now, because what's there now does have the potential, in my view, to be, well, a paradigm shift, frankly, between where the NHS has been for the past 50 years and where it needs to go if it's going to successfully achieve its goals. I have been speaking for far too long, too much detail. I'm going to stop, and maybe people would like to make contributions or ask questions. Lucy.
Yeah. Thanks ever so much for that quick gallop through there, Phil. There was an awful lot of content in that. I'd like to just, I mean, we've only got a few minutes. Well, we've got 2 minutes actually.
So sorry.
No, it's fine. There were questions, especially Kirsty got in there. I think she did quite well. Anyone got any quick questions? Oh, Kirsty says it's good, so that's good.
Great, thanks, Kirsty.
Anyone else want to have a quick question with Phil before we close?
They're all totally shell-shocked.
Yeah, I think actually, I mean, I'm just really pleased to hear that we're not going to go through another reorganisation.
Well, all I'm saying is everybody, you know, I think Wes would be mad to even contemplate it. I think there may be some stuff in primary care, because they've signalled that now, and I think that would be an early thing if Labour win in 2024. But I'm sorry, I'm trying not to. I think that's the most likely outcome given the polls at the moment. That's what I'm talking about. So I think that I think that if anywhere, primary care is going to be the area for development. Yeah. Well, it looks like you've got a lot of people saying that they've enjoyed the session, and you've kept the participants. They haven't been dropping off. So obviously they were listening in, or they were, you know, doing whatever. But
I think that was a really great session.
Okay.
You know, just to be able to understand that. I mean, I certainly hadn't gathered quite the sort of all the different levels there. So there's lots of different ways. I think the big challenge for social enterprise is that there's so many ways that it's hard to see. And my question was really around that. How do we influence the ICS? And I think you're right. It's like, how are they going to hold their feet to the fire if they're not doing those things that actually are going to help local communities?
Personal relationships. I mean, ideally, you as, let's say, a chief executive of a social enterprise in the health space, the chair of the board or the chief executive has got your number and knows you by person and would ring you. And you know, if you get to that point in a personal relationship with some of these system leaders, that really matters.
Yeah. Okay. That's great. And thanks very much for that. And I'll let so I'll sort of bring the session to a close because we're now on 4:30. Yeah. But thank you very much, everybody, for attending. We will be, as Sophie says, we've got the slides, we've got the recording. So if you want to go back and examine those different diagrams, you know, at your leisure, then feel free to do so.